All right, hey everybody, welcome. Let's see. And Rachel, can you just keep an eye on the waiting room and then admit people as they
Absolutely.
log in? Great. Well, so thanks everybody for joining us today for our Learning Cafe. Probably just give another minute or two for it looks like there's still people joining, so we'll give them a minute or two to join up. I appreciate you all taking the time to join in with us here today. I think we've got a good group. I'm gonna go ahead. I'm gonna go ahead and share the slides, share a PDF of the slides for anybody who wants them. I'm gonna put it in the chat, so you should be able to download it straight out of the chat if you want those. And if you have any problems downloading that or that doesn't work for you, you can just message us or email us, and we can send those out to you individually if we need to. All right. Good deal. And double kudos to all of you who are leaving your cameras on as a presenter. Super appreciate that, being able to see some people here. So thank you all for those bold enough of you to do that. Well, looks like things have slowed down, people joining, although now that I say that, I'm sure we'll get an onslaught. But I'm gonna go ahead and get started. I just encourage everybody to leave your audio muted just to help reduce distractions. If you do have a question at any point today, feel free to type it into the chat. I'm gonna try to monitor the chat as best I can as we go along, and I'll answer those questions. And I'm definitely have set aside time at the end for anybody if they have questions and want to discuss anything. Please don't hesitate, again, to put it in the chat. So welcome to our June Learning Cafe. My name is Caleb Corwin. I'm going to introduce myself today because many of my colleagues are occupied with other activities. So I'm both your host and your presenter. I am a psychologist at the University of Tennessee Graduate School of Medicine Center of Excellence. We are kind of a consultation service for Department of Children's Service to help for when we have kids who are in custody who are struggling with placement or with treatment, and we help them to do some consultation and provide some recommendations regarding those topics. We also help to do trainings across the state for providers who serve kids who are in state custody on evidence-based practices. So you may have attended a learning collaborative with us in TFCBT or PCIT or any of the alphabet soup that we typically roll out for evidence-based practices that are good for kids who are in custody. So I'm originally from North Carolina, but I've been at the COE. Originally came over here to do a postdoc after I did my graduate degree at Louisiana State University. And I then did a stint at Cherokee Health Systems doing integrated care and came back here in January. So happy to be back and have the opportunity to present to you all. So today, what we're gonna do is we're gonna talk a little bit about trauma and adverse childhood experiences. I'm hopeful that for most of you, this is not gonna be your first presentation on adverse childhood experiences. Today's goal is to talk more about assessing and addressing and treating trauma than it is to discuss adverse childhood experiences specifically. And so if this is your first exposure to adverse childhood experiences, I'm going to go ahead and encourage you to write down the name Nadine Burke-Harris. She's phenomenal. She's Dr. Nadine Burke-Harris, the first ever Surgeon General for the state of California. She does a talk on adverse childhood experiences that I could never hope to live up to. She's a personal hero of mine. She's phenomenal. She's really getting the word out about the needs of kids. So really, I encourage you to look into that if that's something that's new to you. But I imagine if you're joining this talk and in the state of Tennessee, there've been a lot of efforts to talk about this. So hopefully this isn't your first conversation about that. So when we talk about trauma, I think one of the first things, potentially most important thing to talk about is self-care. And I know oftentimes you'll tend to talk on trauma, and like the last slide will say, hey, take care of yourself. I'm going to flip that a little bit. And I'm going to say, if we're going to talk about trauma, if you're considering working with kids who have trauma, probably you already are working with kids who've experienced trauma, you need to already be thinking about self-care. And so we're going to talk about that for just a couple of minutes on the front end. And I hope you all will just kind of humor me in talking about that, because this is really important. I say it's important because we know that there's a significant percentage of behavioral health professionals who are likely to experience compassion fatigue, somewhere between 13 to 49%. There have been estimates that if you work in child welfare, up to 60% of people in child welfare in one study met criteria for PTSD, right? Working with trauma, helping to address trauma is real and has a real impact. It can lead to people having headaches, muscular pain, depression. It can decrease your awareness of your own burnout. Oftentimes, behavioral health therapists are great in identifying trauma symptoms in other people, but notoriously terrible in recognizing their own symptoms of burnout. And so just because you're like, I'm an expert on trauma, I'll know if it's happening to me, the evidence doesn't bear that out. The evidence says the opposite. You're probably less likely to note it in yourself because you have an increased level of confidence that you're going to notice it. And I think one of the most important things that I want to highlight here is that if you're burning out and if it's getting to you, you may not notice it, but it's probably negatively impacting your therapeutic effectiveness. You're going to find it much, much harder to be empathetic and compassionate with your patients. And that's why you're doing what you're doing, for those of you who are behavioral health clinicians. And so I just encourage you to be aware that as a behavioral health professional, self-care is not something that you do if you need it. It's something you do as part of your job. And I say that because we know that self-care can work, but there are a few caveats to that, right? Evidence is most supportive for prevention, for having a plan for how you're going to take care of yourself ahead of time and enacting that plan on a regular basis. Some of those things might include mindfulness, self-reflection, exercise, yoga, all those things that we can think about. There's evidence for a lot of those things. But even beyond that, there's more evidence. Some of the most impactful things are creating work-life balance, making sure to take time away from work to do other activities that are important to you, trying to have a variability of professional activities so that it's not just therapy if you're a therapist, and trying to have some flexibility in your work. Now, I know not all of you are going to have control over all of those factors. They're going to be related to your work environment to a certain degree, but I encourage you, for those of you who are able to advocate for that and to have that, to do that as much as you can, to really try to embrace the flexibility you have in your work roles, because that can really help. And then the other thing is sleep hygiene. In therapy, I talk about this time and time again, the importance of sleep. Actually, our next presenter for our next Learning Cafe, Dr. Ari Ravid, is going to talk to us about the importance of sleep and how to address sleep problems with kids, but it's hugely important as a behavioral health clinician as well. And I encourage you all to focus on that, taking care of your own sleep needs and making sure you're getting enough sleep, because that sets you up for success. So I'm going to encourage everybody to take just a minute and just write down one thing you can do this weekend, just seriously and very seriously. I want you to think about this before we talk about the tough stuff. Just one thing that you can do that's going to be recharging for you this weekend, or if you don't have weekends off, your next day off, what you're going to do, whether that's spending time with family, whether that's turning off your work email. I mean, whatever that self-care needs to look like for you, I really encourage you to consider that now before we talk about that, because I think self-care is something that's better focused on before you need it, right? You may need it after we talk about trauma. All right. Okay. So now I'll get into what you actually came here to hear me talk about, right? So we're going to talk about adverse childhood experiences, right? Or ACEs, as they're commonly called. So ACEs, as most of you know, came out of a study in the 90s. Felitti and Anda did a study, and they found that among their 10 adverse childhood experiences, including physical abuse, sexual abuse, physical and emotional neglect, domestic violence exposure, parental substance abuse, parental mental health concerns, parental divorce, and that your exposure to those was related to your later subsequent life development of a number of significant health outcomes. They found that 61% of adults had experienced at least one adverse childhood experience, and up to 16% had experienced 4 or more adverse childhood experiences in their lifetime. They found that there was this dose response curve where the more adverse childhood experiences you've experienced, the more likely you are to have these negative health outcomes. And for somebody with 4 or more ACEs, it made them 7 times as likely to experience depression at some point in their life and 12 times as likely to commit suicide. So these were associated with significant mortality, but they're also associated with significant health outcomes. And so they found an increased risk that you're 3 times the risk of heart disease, right? If you experience adverse childhood experiences. So it's not just tied to behavioral health outcomes. And again, I encourage you, if you want a lot more detail on this, Dr. Nadine Burke-Harris is going to give you the ACEs talk, like your primer foundation ACEs talk. One of the reasons, the mechanisms that they found since that study is they've tied it into the bodily system of the hypothalamic pituitary adrenal axis, right? It's our body's stress response system. And what they found is repeatedly that the way this system is intended to function is a stressor arrives and our body responds. It triggers our body to release cortisol so that our body engages, our heart pumps, our muscles are prepared to respond to a threat. That threat comes, we either fight it, run away, or die. And regardless, our stress then goes down, right? At some point, it's time limited. It's intended to be short-lived. But when we talk about these adverse childhood experiences, we're talking about parental substance use, physical abuse. So many of these things we're talking about are chronic. They're things that don't happen in an isolated incident, but happen day in and day out. And when that stressor is occurring repeatedly, it has a tendency to disrupt this natural bodily system, so that instead of starting and releasing cortisol and then calming down and engaging our rest and digest system, this hypothalamic pituitary adrenal axis is constantly activated. And as part of this system, what happens is it suppresses our natural immunity and it causes our body to be constantly inflamed. And so we see for children who are experiencing this, and that system is pressed into action over and over and over again, they have a much higher increased risk of infection, and it disrupts their inflammatory response. So we see kids who have been exposed to significant doses of adverse childhood experiences developing diabetes at a much younger age. We also see them developing and presenting to primary care clinics with respiratory infections at a degree much higher and with higher rates of asthma. So even at a young age, we see physical health impacts of this repeated exposure to stress. We know that the impact isn't just on those kind of physical health symptoms. We also know it affects brain development. Whether you grew up in a stressful household or a nurturing, supportive household affects the way that your brain wires and develops. One of the sayings I heard over and over and over again in graduate school was, neurons that fire together wire together. Right? The experiences that we have in our life affect how our brain pathways develop. And so if we're constantly being confronted with stressful situations, the parts of our brain that are in charge in responding to stress are going to become stronger. And that if we're very rarely presented with opportunities to relax and be presented with a nurturing caregiver, our brain is not going to be well wired to respond adequately to those situations. And so what we see is our body's alarm system becomes really big, because our brain gets really good at recognizing threats. And so that part of the brain is allocated more resources, right? Those neurons myelinate and develop more connections. However, the part of our brain that's in charge of sitting down and processing things, our brain's search engine, our learning capability, which functions best at rest, is not actively engaged and not regularly engaged. So it doesn't get practice. So it's often underdeveloped, right? And we think about that for kids who have grown up in those stressful environments and present with learning problems, right? That part of the brain hasn't been given as much practice to develop. And when those two things combine, you've got a heightened alarm system. and a really poor processing system. It doesn't really bode well for the development of frontal lobes, which is in charge of decision making. So we see a lot of kids who have grown, and adults who've grown up in this high stress environment, who are presenting with executive functioning deficits, right? They struggle to process information, to control their impulses, and to make logical decisions, or decisions that are in their best interest most of the time, because their brain or in their long-term best interest, because their brain has been primed to survive these short-term threats over and over and over again in a different environment than the ones they may enter when they're in foster care or once they're out of that stressful environment. Hey, one of the things that I think is important to talk about when we talk about adverse childhood experiences and we talk about trauma is the impact of racism and historical traumas, because this was initially not included in Felitti and Onda's study, but subsequent research has really pointed out the importance that we consider this, because we see that there's a significant discrepancy or difference between how frequently people of color experience adverse childhood experiences versus others. And we know that people of color are at a much more increased risk of experiencing adverse childhood experiences than others. We know that there's a higher risk of multiple adverse childhood experiences. We know that there's an increased risk of socioeconomic barriers and poverty. And we also know that there's the additional adverse childhood experience associated with discrimination, and how that impacts people of color in their perception of safety in the world and their community. And this is an important, and they're gaining traction in trauma treatments. There are a lot of trauma treatments that are gaining evidence in helping to address some of these situations and some of these traumas that are uniquely experienced by Americans of color, right? People of color more broadly. And we also know, and just to speak to this, that historical traumas play a role, that there's an intergenerational transmission of trauma, right? And that we know that this can affect not just in a biological way for any singular person, you know, how it may lead to the development of heart disease or asthma or obesity or diabetes, but that it can affect on a genetic level that can be passed on. And that I say that to say there are a lot of things that it's going to take a lot of work to repair, right? There's a lot of work to be done here, and there's a lot of need for people to be more aware of the impact of trauma so that we can work to help our communities to address some of these concerns. So that was our brief primer on adverse childhood experiences. Again, I'm going to plug Dr. Nadine Burke-Harris. I think she's great. Go watch her talk on this. But now I want to talk about what can we do about this, right? What's to be done? And one of the things I want to be clear on is, it's going to be hard to do show of hands here, right? I don't want to take the time necessarily to do a poll, but I imagine many of you are behavioral health professionals. It's our typical attendance, right? It's people who are in the behavioral health profession to some degree, or people who work in child welfare. And one of the things I encourage you to take this information, adverse childhood experiences, and to look at the population you serve in a different way, right? To understand, to adopt a new lens to look at them. Because for those of you who are in behavioral health, there may be those among you who think, well, I'm not trained to treat trauma, right? Like I haven't been to a TFCBT learning collaborative, and this is not intended to replace that, right? I strongly encourage anybody who hasn't received formal trauma training to do that. But I also want to encourage, for those of you who haven't had formal trauma training and are continuing to serve kids, which you should, and I appreciate all of you for doing that, that you're still treating trauma. And I encourage you to think about your patients differently, because if you're treating learning or behavioral problems, unless you're already screening for trauma, you're probably treating trauma, right? Because we know that children who present to the clinic with learning or behavioral problems are at a significantly increased probability that they have experienced a significant number of potentially traumatic events in their life through adverse childhood experiences. We know that people who present to our clinics with substance use, odds are, if you're struggling with substance use, you have experienced a significant number of adverse childhood experiences or potentially traumatic events in your past. If we talk about ADHD, and I don't know that I've talked to a child serving behavioral health clinician who didn't have a patient with ADHD, right? I mean, that's across the board. If you're serving kids, you're seeing somebody who has ADHD. Well, there's a significant amount of symptom overlap between children who are exposed to trauma and struggling with trauma reactions and children who are presenting with ADHD. And unless we're actively looking to parse that apart, we run the risk of missing it, right? Or misdiagnosing, mislabeling some of those difficulties. And so what I hope to help you all to do is to think about some ways that you can identify that, right? And so I want to share with you all some ideas for ways that you can uncover some of these things in your current patient population. One idea is through routine screening. There are a number of ways to do routine trauma screening, screening for trauma exposure, and some of these are fairly simple. I listed these on there. I listed the ones on here are on there because they're free, and that's my favorite price point for any mental health intervention or mental health tool. These are also all readily downloadable off the internet, so they're very accessible. They're very simple to find, and so I strongly encourage to look at these. You'll see that they're vary in length, but most of them are pretty short. They also vary in which age ranges they target, so that's something to pay attention to, right? If you're serving mostly adults, you're going to want to pick something like the life stressor checklist. But if you're serving mostly kids, I like the pearls is one of my personal favorites, but there are a number of out there. I'm a big fan of the pearls. It was developed by Dr. Nadine Burke-Harris. As you can see, big fan. One of the things that's important is when we think about trauma for kids, we so often forget the most prominent form of childhood trauma, which is neglect. Anybody working in child welfare is well aware of that, right? That is one of the most common reasons or what ends up being substantiated that leads to child welfare becoming involved. But it's for many kids and many people who aren't trained to work with kids with trauma, it's not often thought of as a criterion A event, but I encourage you to think about this differently. If you have a 1-year-old that's parents are passed out, and not caring for them, that is a life-threatening event, right? If that child doesn't get adequate food, we know that if, children who grow up in environments that aren't nurturing, that affects their physical health, right? Failure to thrive can be related to that lack of that emotion, that attachment relationship. And so that can be, we have to conceptualize some of these things differently when we're talking about kids than we may think about them when we're thinking about adults, right? And so making sure that your screener is including that, includes some screening of neglect and not just car accidents or a house fire or other things that are important to screen for, but may not meet this list. This is just an example, and this isn't actually the full list, the full questionnaire. I couldn't get it tonight. It didn't look nice when I shrunk it down, so I only gave you half of it. But this is the pearls, right? The screening that was developed by Dr. Nadine Burke-Harris, and it's something that is important to address, to think about, right? To think about how many of these events somebody has been. Hold on. So it's one way to ask this question in a non-threatening way. Sorry, there's one question about, will we get a more honest answer if we wait a while after meeting a child before jumping into a trauma screening? I think that's a good question. I definitely think sometimes we do get a more honest answer after we've built rapport with somebody. But I also think that a lot of times, especially with younger kids, we're asking a caregiver or other team members, right? We're talking to sometimes the foster care worker. But yeah, sometimes this will change, and it's worth doing repeatedly, especially if you have a suspicion, right? Asking this question, but I wouldn't let that stop you from asking the first time, right? Because you may get that answer the first time and you're not going to know unless you ask. I like this screener because it asks them to write down how many experiences they've had instead of writing down which ones, which is often less threatening. It's a de-identified screener. And then once you know the number, say they write down a 6, Now I have a way of thinking, oh, I better follow up on this. And I may follow up and they may tell me nothing. They may say, oh, I don't want to talk about that. I don't want to give you the details. That's okay, because now I know that I can repeatedly follow up on that. And once I have rapport, I know that that's something I need, because if they've had 6, chances are there's some stuff in there that's potentially traumatic, right? It's not just kind of risk stratification for me and thinking that this person has an increased risk of heart disease. It's, this is potentially more relevant than that. And it just gives me a foot in the door to have that continued conversation. But I encourage, I do this at intake, right? This is part of my initial screening process and my intake appointment. But that's rarely the last time I'm talking about it, right? One of the things that I think is going to be really important to highlight, whether we're talking about adverse childhood experiences or potentially traumatic events, which are 2 different things, right? Adverse childhood experiences is that set list of things. Potentially traumatic events may include more things, right? A car accident is not on the ACEs checklist, but could be a trauma. But regardless of whether we're talking about potentially traumatic events or adverse childhood experiences, what we know is that exposure to an adverse childhood event, experience, or traumatic event does not lead to a diagnosis. We know that, in fact, resilience is the norm. Most people, if we look at that original ACE study, we know that people who have experienced 4 or more ACEs are at an increased risk for all of these things. But we still know that in the majority of cases, 75% of people who experience 4 or more ACEs do not develop those negative outcomes. It's not that everybody automatically develops negative outcomes. And it's definitely not true that everybody who's experienced those things develops PTSD. There are probably people on this call right now who have a high ACE score and have experienced potentially traumatic events in their life, who went on to be very successful, do not have health concerns, have not developed PTSD. And I think that's really important, because I don't want to encourage anybody to assume that, okay, I've screened somebody for trauma, for ACEs, and now they've got this, right? Now we're doing trauma treatment, because not every kid who's had those experiences needs trauma treatment. People who've been exposed to traumatic events and have developed traumatic stress reactions, they will benefit from trauma treatment, right? And so now we're going to talk about that next part. How, if we know somebody's been exposed, how do we then know if they're symptomatic or if they need to benefit from a trauma treatment? And one of the ways to do that is through a trauma assessment. This is where you're using your clinical interviewing skills, if you've got them, right? You're working to determine if they're going to meet criteria for one of our trauma-related diagnoses. We're doing our semi-structured, unstructured interview to look for hypervigilance, avoidance, intrusive thoughts and images related to that traumatic event. We're trying to see if they're re-experiencing it on a regular basis. This assessment process can be the beginning of treatment. And I encourage anybody who's working with kids and incorporates this into your practice to think about it this way. Because even if you're not doing TFCBT, if you're doing a trauma assessment, you have an opportunity to be doing some therapeutic trauma interventions. Because the part of the process of collecting this information involves talking about these symptoms and providing some psychoeducation. And as you talk about those symptoms, you normalize that experience for that person, right? So there are a variety of ways to assess for traumatic stress reactions. My personal favorite is the CATS, the Child and Adolescent Trauma Screen. Again, it's at my price point of free, and so I use it a lot. But there are a couple of others on here. One of the things you'll notice is that the Trauma Symptom Checklist for Young Children has a price tag. That one's not free. And if there was one for young children that was free, I would have listed it on here. Unfortunately, we don't have a lot of great tools to assess traumatic stress reactions in young children. But the one we do have, unfortunately, costs. I'm hopeful sometime in the near future somebody's gonna bootleg that, or come out with some free version of that, which is inevitably what happens with most of these others. But we'll see. But for the time being, these are designed to hit at those main criteria for PTSD, right? They're assessing within each of those categories and giving you a sense of whether or not this child's experience of that symptom is more than what we would expect for that kid. This is on the left, you'll see that's the CATS. You might not be able to read this, but you can, if you Google child and adolescent trauma screen, you can download it in a far more legible format. But it's 20 item questionnaire, right? There's a caregiver version and a child report version. And it goes through, and each of those questions kind of goes into one or the other of the main clusters of symptoms of PTSD. And on the right, you'll see the breakdown of how to interpret this, understanding that for older kids, we're going to interpret it one way, and for younger kids, we'll interpret it another, right? And so you'll see that there are just two different ways of interpreting this. But again, very simple, pretty straightforward. Doesn't take a lot of training. This is not something that you're going to need a lot of practice on. You don't need to go to a special training to learn how to do this trauma assessment. This is something that if you've given Vanderbilt rating scales to assess for ADHD, you're pretty well trained to do this, right? You're going to go through, you're going to add them up, score it, and then you're going to provide them feedback. One of the ways I encourage you all to think about this, though, what we're thinking about is trying to get them to a diagnosis, because the diagnosis is going to lead them to treatment, right? That's why we give diagnoses, is to inform treatment. Sometimes, though, there's this feeling, and I've had it early on in my career, of I need to get the perfect diagnosis before I start treatment, because if I don't have that perfect diagnosis, if they don't meet all the criteria, I'm going to do something potentially harmful. And I think that fear was real for me, and I want to validate that for other people. But I also want to highlight, if we take 3 or 4 sessions before we start treatment with somebody because we want to get the diagnosis perfect, how many sessions, like what's the modal number of sessions, therapeutic sessions that people attend? It's 1. Most people don't attend multiple sessions of therapy. And so if we're not helping our patients to feel like they're getting something early on and that they're connecting and we understand what's going on for them at a fairly early period, we run the risk of losing the opportunity for intervention. And so I have this slide on here to help people broaden and understand that you can broaden your category of what you're using. It doesn't have to be PTSD, right? If it doesn't meet the criteria for PTSD because the event is too recent, then maybe they meet criteria for acute stress disorder, right? Which is still very similar, almost identical cluster of symptoms, right? But the time period is different. And maybe they don't meet criteria because you just don't know enough. There's a lot of stuff there. You're seeing some traumatic stress symptoms, but you haven't fully finished your trauma assessment. But you're pretty sure, based on your clinical interview, that there's some stuff going on there that's related to their trauma. You can use the diagnosis of trauma and other stress-related disorder, which is kind of our NOS, not otherwise specified category. And you can use that for billing purposes, and then go on to start some of the treatment, right? And I think that it's important to think about things this way, because if we're holding out to, like, especially as we think about, should we wait to ask these questions until we know a patient better? Well, if we wait, then we're holding back this potential intervention that may be helpful for somebody, right? If we wait to ask those questions. Now, if we ask them and they don't give us an honest answer, that's okay, but I feel better about that personally, right? You weren't ready for that, and that's okay. We started with some lower level stuff until you were ready. But if it's because I wasn't ready to ask those questions, then I feel differently about it. And I encourage everybody, especially those of you who are behavioral health professionals, to get comfortable with asking these questions. Our patients need us to ask these questions. Some of our patients have lived through these experiences and are struggling to overcome them. And so ask the questions so that you can get to the intervention and have some of these conversations with them, right? All right. Oh, there were a couple of questions. So one of the questions was, so, and this is actually maybe several slides ago, is the risky lifestyle choice such as drug and alcohol originally used as a coping mechanism that is creating a health issue in most people with high ACEs? That's actually an excellent question, and one that is very relevant, and Dr. Nadine Burke-Harris hits it perfectly. So again, plugging that. But what they found is, yes, there is actually a relationship. People who have experienced a higher rate of adverse childhood experiences are more likely to engage in negative coping, such as substance use, smoking, some poor decision making earlier on in life. But the other thing that is also true is that even when they controlled for that statistically, people who did not engage in those high-risk health behaviors still had negative outcomes, still were at an increased risk for depression, we still were at an increased risk for heart disease and those negative outcomes. That actually didn't predict the risk of the negative health outcomes. And so that's a really good question. It's actually, what the evidence points to is that it's much more likely the negative impact of the repeated stress exposure with the hypothalamic pituitary adrenal axis, that's what's leading to those negative health outcomes. That's a really good question. And again, Dr. Nadine Burke-Harris, she nails it. So now I'm going to talk about, so you've assessed for this, and you're sure at this point that the patient that you're treating is having some type of traumatic stress reaction or a traumatic stress symptoms, right? That indicate that you should use a trauma treatment. So I'm going to talk about some ways to do that. So I want you, to think about we hear about evidence-based treatments all the time, the importance of evidence-based treatment, and it is important. And I'm not trying to talk down about evidence-based treatment, but it is talking about something highly specific, highly manualized, and it's designated as something that had 2 large-scale randomized controlled trials by independent investigatory teams that came to positive conclusions for that, right? And those are not bad, but there's also evidence-based practice, which is a broader category that is designated to intend, it's using the best possible research while including your clinical expertise and client characteristics and preferences to treat the patients who are in front of you, right? And this is something that I think we have to think about flexibly, because I bet everybody on here hasn't had an opportunity to go and get trained in an evidence-based treatment for trauma. Not everybody has been through a TFCBT or a CPP learning collaborative. Although if you get the opportunity, you absolutely should. But if you haven't, that I want to highlight, if you have been trained in other evidence-based practices, there's a solid chance you have the tools in order to you have the tools necessary to effectively initiate change for people who've experienced trauma, right? So one of the ways to think about that, and one of the ways that can be done, is to think about things a little differently. There are a couple of approaches that have become more popular recently, and they're kind of common elements approaches. Diagnostic treatments is another way to think about it, or evidence-based kernels. One way to think about this is taking these evidence-based treatments and finding what are the active ingredients, right? So you may have ART or TFCBT or CPP, all excellent treatments. Again, if you get an opportunity, go to the trainings for those. But you may not have that opportunity. And what researchers have found is that there are a lot of commonalities between those treatments. And using some statistical analyses, but also just some logical reasoning, are those treatments effective because of the specific way that they're packaged, or are they effective because of the commonalities that they possess, these active ingredients, these common elements that are similar to each of them that are actually working to impact the change? And some of the elements that are common to trauma treatment are also common to other effective evidence-based treatments. And so the assumption is that because it's similar to that it's likely to be effective for other concerns as well. And the evidence has shown that as well, that common elements approaches have been effective in treating a variety of different treatments. If you have somebody who presents with anxiety and you give them a depression treatment that's evidence-based, their anxiety gets better, even though that treatment wasn't designed for anxiety, right? We're thinking more flexibly about using our clinical skills. When we apply this to trauma, there have been a few different ways to think about this, right? One of the lists that was proposed by Dorsey et al. When they looked for a common elements-based approach to treating trauma is they looked at all those treatments, and what they found in the middle of that Venn diagram, the similarities, pretty much all of these evidence-based treatments included a psychoeducation component, a component where you're talking about common PTSD symptoms, you're outlining treatment. They have an emotion regulation component. They have an imaginal exposure component, an in vivo exposure component, some form of cognitive processing, and some form of problem solving, right? So for those of you not trained in an evidence-based treatment for trauma-informed therapy, do you have clinical tools in your skill set that fit into those categories, right? I mean, I'm willing to argue that most of you, if you have done the coping cat, or you've been trained in CBT, or you've been trained in DBT, you have learned strategies for emotion regulation. You've learned strategies for doing cognitive processing. You've learned strategies for teaching problem solving. And hopefully, if you graduated a training program to provide behavioral health services, you were taught how to do psychoeducation, right? That's pretty common across the board. And these are components that can be effective. And so when we think about using this common elements approach, it's not about one specific way of doing this. It's not about one specific script for psychoeducation. It's trying to do it in the spirit of psychoeducation, right? So doing education on what are common reactions to trauma, what are helping somebody understand that it's common for people who have experienced trauma to experience triggers that cause them to re-experience, have flashbacks. It's describing what the course of treatment is going to look like so that they can understand that there's a path towards hope, right? That there's a path towards improvement. And you're having that discussion. And for so many patients, we see a really positive reaction with this initial psychoeducation, because we'll see that, you know what, especially I'll see this in adults who weren't aware. I didn't know what was going on. I thought I was going crazy. These things were popping into my head and I didn't know what was wrong with me. And now we've given them a different lens through which to view themselves. And that can be so powerful so many times. And so psychoeducation is part of the intervention. Sometimes it's one of the most important parts of the intervention, especially when we're talking about within a family unit, because maybe the kid's not feeling overwhelmed by it, but probably they are. But the parents are probably really struggling to understand what's going on with the kid, and we're providing the parent with a new lens through which to view their child's behavior. Your child is not yelling and screaming because they want to make you have a bad day. They're yelling and screaming because they're reliving this really horrible thing that happened to them in the past. And sometimes that redefining within the family system can allow parents to dip deeper into their well of patience and retry some of the other interventions that you may have been talking about and may not have worked well, because the family was like, well, the kid just won't do it. They don't want to, right? And so that psychoeducation can be so helpful. We talk about emotion regulation. I wish we had more time, because I would love to hear from you all what you all use for emotion regulation. Every time we're able to have a discussion about this, I always end up learning so many things from different ways people do this with kids, because child therapists tend to get so creative. But we're talking about teaching our patients and their families how to engage in emotion identification, right? We're connecting thoughts and feelings, or connecting feelings to different events and physiological responses. We're teaching different relaxation and mindfulness skills. I remember I learned pizza breaths from Dr. Berkeley. I don't remember who I learned ninja breaths from, right? All different things that people can do. Tucker the Turtle, right? Different strategies, different things that we can teach kids, ways we can teach kids how to recognize their emotional experience, and that they can have some level of control over their physiological response to calm themselves back down and to normalize those emotional experiences. Because so many of our kids who are struggling with trauma don't have the words to put to the feelings they're experiencing. And so that, along with the psychoeducation, allows us to help them to do that. And again, I'm not talking about one specific way of doing this. If you have a child who's having traumatic stress symptoms, teaching them emotion regulation skills is helpful, right? That is something that is worth doing within the context of their treatment. Also with cognitive coping, right? Teaching them how to think about their thoughts and the relationship between their thoughts, their emotions, and their actions, right? That cognitive triangle. Teaching them how to think and challenge some of their thoughts. Does that thought make sense? You know, what would you say to a friend who was having that thought, right? Helping them to step outside of that box and re-examine their thoughts to make sure that that thought makes sense, that it's not full of self-blame and self-doubt, that it's not something that they've carried with them because of that traumatic experience. And as you teach patients cognitive flexibility, we know that that is a skill that predicts a more positive prognosis, right? A more positive outcome for our kiddos, the more they're able to be cognitively flexible. And so if you have a skill set, if you have a strategy for doing that with a child, teaching a child to be cognitively flexible if they've experienced trauma can be an effective intervention, right? And can set them up for later success. Problem solving, right? Hopefully many of you have strategies for problem solving here, right? Different ways you teach that to a kiddo. My personal favorite is just teaching the problem solving approach, how to brainstorm and then examine different possible avenues and then test out the avenues and see which one makes the most sense. And with kiddos, I always do that in my office, and I just put a crayon on the table and I say, you got to get this out of my office, but you can't touch it with your hands. Inevitably, the little boys say their first idea they come up with is that they're going to karate kick it to the door, right? That's the first idea. And we go through and I let them try. I had one kid who did it, and that kind of backfired because that was his favorite idea, but most of the time it doesn't work. And then we get to examine how the first idea that pops into our head isn't always the best idea. Sometimes it's the third or fourth idea that ends up being the best idea. And we're teaching how to think things through, how to examine and understand that even if we're really intelligent, maybe the first idea we have isn't the best idea. And so we're talking about a lot of those things. And we're also talking about planning for that with parents, right? How do we teach parents to guide their children through problem solving, and so that they can address problems that come up at home in a more collaborative way? Anybody who's trained or been exposed to collaborative problem solving, it's an excellent intervention, but can be utilized here and can be helpful for families. And then exposure. Right? Exposure is the one that I think most clinicians get gun shy about when we start talking about trauma. And exposure, there are a lot of different treatments that do this different ways, but at the end of the day, it's typically focusing on doing things gradually over a period of time, right? We're doing things where we're talking about what are the subjective units of distress, right? How much does this upset you? Getting a rating scale for that, and then creating like a fear hierarchy and stepping through that, right? Here's what you're doing. We're going to start with something that's easy. What are you going to do? How upset are you right now? What's your rating? Oh, it's a 3 out of 10. Okay. When it gets to a 6 out of 10, what can we do to calm down? How can we tolerate this? So we can build success with doing some of these things that give us anxiety. And the theoretical explanation for this is, as we do things that make us nervous, the more we do them and experience success with them and show ourselves that we can do it, the less anxiety we have the next time, right? It's this habituation. We're repeatedly exposed to it and we get more comfortable with it. And that's kind of, in some ways, part of the argument for the trauma narrative. Now, the trauma narrative is far more complex than that, but we're doing this kind of repeated presentation of this over and over and over again, right? And you're doing a repeated review of the narrative and doing some of that cognitive processing during that time. But I want to be clear, trauma narrative should only be done with proper training. I don't want you to walk away from this and say, oh, Caleb said that I've been trained to do exposure, so I can do a trauma narrative with a kid who's experienced trauma. That's definitely not the message I'm sending here. If you've been trained to do trauma narratives with kids through TFCBT or another modality, by all means, right? But you may get to, you may be treating kids and you've not been trained in that. And in that case, I don't encourage you to wing it. Trauma narratives are not something that I'm going to encourage you to go out there and just give it a shot. The other parts of this, I will, right? The other parts of this, for the, if you have a child who's presenting with traumatic stress symptoms that you've assessed with some of those tools we talked about, and you know that's part of their presentation, do emotion identification, do cognitive coping, steal shamelessly from the coping cat and use that part of the coping cat with them, because they're probably going to benefit from it, as long as you can bring in the dialogue of how those anxiety symptoms relate to their trauma and those other things, right? And you're bringing trauma into the conversation. And by assessing trauma and doing that psychoeducation, you are doing exposure, right? That discussion of their traumatic experience is exposure. It's not the trauma narrative, but that's okay. It's still trauma treatment, and we know that is still likely to benefit the kids who are in front of you, right? Some other considerations for those of you who are trained to do narratives, right? You want to make sure that you've engaged the caregiver and that you've got a low risk of kind of self-harm or uncontrolled depressive symptoms, because the trauma narrative is likely to make somebody worsen some other symptoms, right? It does put them in, we do often talk about caregivers before we do it, because we want to make sure they're aware that as we talk about these things in depth, they're going to have a reaction. There's a good chance that it's going to be difficult for them, right? And so we want to make sure that we've prepared those caregivers in advance of a conjoint session. And again, those of you who had training in doing a trauma narrative, I encourage you to lean on that training, but what we're talking about is being careful that we're making sure that the caregiver is provided to have is prepared to have an adequate response, and that's a good caregiver to share the narrative with. That's a supportive caregiver, right? Not every caregiver has a narrative shared with them. And again, I also don't want you to hear me say, well, I'm not trained to do a trauma narrative, so I can't do any kind of trauma work. That kids who have been exposed to trauma and have traumatic stress reactions, I can't see them, because that's not what I'm saying. What I'm saying is there are things you can do. You can do that psychoeducation. You can build their coping skills. You can do gradual exposure through periodic discussion of these things. And you can work to address barriers to the narrative so that you can set them up if they need it. If you've done that and they're still symptomatic, you can refer them on to another clinician. I know I used to say, well, you need to refer them to somebody who's trained to do this from the get-go, but I also know that everybody's not readily available. Like, there are long wait lists, and this patient is the patient who's on your caseload. There are things you can do to put that patient in a good position to do that work with somebody who is trained, or until you're able to get that training if you're working on it in the meantime, right? And I want to highlight the importance of including the family in this, right? Finding the family. We know that most interventions for kids are more effective when we have family participating, when we have supportive, non-offending caregivers who are participating in treatment. We know that there is a greater likelihood of success, and that the gains we have are more likely to be sustainable over time. And so, to the degree possible, and I don't know what settings you all work in, so some of those lend itself more readily to that than others, but it's really important to consider that, and to, as much as you can, work to include supportive adults, because we know one of the biggest predictors of resilience for kids is having one supportive, nurturing adult in their life, at least one person who can ride it out with them, who they can talk to, who they can go to. And to the degree that you can, as a clinician, support that relationship, you're increasing the likelihood that that child finds resilience going forward. Oh. Again, so self-care is critical. Understanding that it's important to understand that people's past affects their current behavior. Regardless of whether or not you're doing trauma treatment, you should probably be screening for trauma at intake. You should make sure that even though you screen for trauma, and just because it's present, you shouldn't assume psychopathology. If they screen positive, you should use your skill set and assess for trauma. And that you can strategically unpack your evidence-based skill set to treat kids who have experienced trauma. Psychoeducation is an important treatment, and trauma treatment works, right? I encourage all of you all who haven't had official trauma training to get it, because it's so powerful. And chances are, if you're working with kids, especially if you're working in a community mental health setting, you're seeing a lot of kids who've experienced a lot of trauma. But get training in official evidence-based treatments, whether it's TFCBT, CPP, right? There are treatments out there, and I encourage you to do that. So to take a moment for any questions that people haven't asked if they want to, but I also want to let you know that the survey is in the chat for you to click and complete your survey, which will also give you your certificate once you've done that, your certificate of participation for today. That's in the chat. But what questions do people have?
There was a question in the chat.
Oh. I have found that psychoeducation requires a shift from adults in a child's life to see a child's behavior as a symptom of their trauma rather than bad behavior. I have a couple of resources that are sometimes effective, but would love to hear if others have tools that have been useful in helping adults to make that paradigm shift in how they look at the child's behavior. No, that's excellent. I also, if anybody has anything, I encourage you to throw that in the chat for ways to do psychoeducation and helping parents that shift. I've used a lot of times when I'm doing psychoeducation with a kid, I will use some of the books. What is it? A Terrible Thing Happened is one. Is it called Jesse or Tell? Somebody help me out. I think Just Tell. But I use a lot of the psychoeducational books.
Please Tell.
Please Tell. That's it. A lot of those books, which have been really helpful, and I'm sharing it with the kid, but adults picking it up a lot of times. I have had parents where I've talked to them about, I've had them watch Dr. Nadine Burke-Harris. This is like probably my 10th plug for that here, but I have them watch that video because I think it's really powerful and it's only 20 minutes long. You know, I lean on the expertise of others or whoever I feel like is going to have credibility with them, who they're going to hear. But there are a lot of really good videos out there that can help parents to understand that if they're not hearing it from me, if it doesn't go well. Yeah. Yeah. And many parents and teachers feel they're giving in by the child by having a trauma-informed perspective. And I've heard that before, but I also think that, you know, that's sometimes a misunderstanding, and working with them to, you know, using motivational interviewing skills to understand what their goal is and how can I join with them on a shared problem focus. And along that path of using my MI skills with them, how do I then also share that psychoeducation, right? And help them to gain that perspective and understand that by taking that perspective, they're actually going to achieve the goals that they have. That the strategies they've been using, unfortunately, aren't working, right? You want to do that tactfully. Yeah. Other questions? All right. Oh, it looks like the questionnaire doesn't let us complete. There's an error in the title. I don't know.
Yeah, so I noticed that as well. When I tried to complete it, you have to enter it in by hand. So there's a place where you can select it. You'll see the title. So just go ahead and click again in the space and hand type it in, and it will let you advance. And if you want to just do an abbreviated, like the first word or something, we'll know what it is. We'll know what the title is. I don't know why it's doing that.
And there's another question about, can you talk more about fostering resilience and trauma treatment? What are some protective factors? Really, we know one of the biggest protective factors are supportive relationships, right? Time and time again, that's the one thing that comes out most consistently. And so that's one of the things I try to encourage, right? Is how do we foster that? Who are the people in this kid's life that we can strengthen the relationship? Can we talk about ways to set up productive one-on-one time with that person so that they have that opportunity to build that relationship? And maybe sometimes that needs to be really structured. We're planning out very specifically what those activities are. Sometimes it's just setting aside free time that's allotted to those two people to spend together. The other thing is, for some kids, extracurricular activities. Maybe that person's not in the home, it's a coach, it's somebody else. How do we build that child's self-esteem? Because self-esteem is another thing that can be protective. It's not football for every kid, right? And so it's also working with the family to figure out what is it for that kid? What is a possible strength? Maybe it's Cub Scouts, maybe it's youth group at church, maybe it's, you know, it could be lots of different things, but trying to encourage those interests as well. Well, I want to be respectful of everybody's time. I appreciate everybody for tuning in with us today. Make sure to do the survey. If you have continued problems with it, you can email us and we'll try to figure that out. I encourage you all to tune in with us next month. We're going to have Dr. Ari Ravid is going to join us, and he's going to talk to us about sleep interventions with kiddos and the importance of addressing sleep. And so I encourage you to tune in with us next time. Thank you all.